try my best to condense them into something that the more important points that you have to remember as far as your competencies are concerned, no? Okay, so I expect that you have been able to go through the initial lectures, history, physical exam, etc. So this will entail two major structural components of cardiac diseases, namely valvular and congenital heart diseases. You talk about congenital heart diseases, they also are in the spectrum of acyanotic congenital heart and cyanotic congenital heart. But in context, we shall limit this to the grown-up congenital heart diseases. For those patients that we get to diagnose in the grown-up context, no. More often than not, the pediatric cardiac disease, cardiac congenital heart will have to be addressed as soon as clinically indicated when they are young. Okay, so this is two parts. The first part is the valve section. So you'll be able to classify valvular heart disease. It's multiple nature, maybe. The consequences of the valve dysfunction and its complications and management plan. So you're able to identify clinically in the past lectures. Now, what are you going to do with them? How are you going to diagnose them? What are guides that entail management for these patients? And for congenital or grown-up congenital hearts, we have its definition, the clinical consequences of both the spectrum, which I have told you earlier. Create a management plan, of course, it's referral, how we're going to go about it, all right? So our first section shall be valves. No, the basic understanding for valves, even in mechanics, hydraulics, is to be able to make blood flow or fluid flow in unidirectional manner. In our heart, which is a vortex creator instead of just a traditional pump, the heart is folded embryologically and it has become very efficient, in creating motion and building pressure. So it moves, fluid moves. However, it has to be governed within the vortex or the heart pump, the heart, in a uniform, unidirectional manner. So I hope you can see my cursor. Are you able to see it?
Yes po, Doc.
Okay. So anyway, so we have the blood coming from the systemic circulation through the superior and inferior vena cava, the right atrium, and then you have your AV valve, namely your tricuspid valve. So this is following the flow of the blood. So the tricuspid valve to the right ventricular chamber, and then to the right ventricular outflow tract through a semilunar valve, the pulmonary valve, into the pulmonary circuit. This is the main pulmonary artery. It bifurcates into the left and to the right pulmonary arteries, and so on and so forth. And then in the pulmonary circuit, you have its blood, the oxygenation and the carbon dioxide. We have gas exchange, basically. However, they should be supplied with blood. Hence, we have gas exchange taking place. So that's respiration. So closely related to lung function. And when we already have our gas exchange successful, it returns to the heart via the pulmonary veins, which are paired on either side, left and right. Enters the left atrium, and then through the mitral valve, another AV valve, left ventricle, and then into the aorta, the aortic valve, and the aorta. So remember, in systole, no, of course, in either the isovolumic contraction or relaxation, all valves are closed. But when the electrical impulses dictate a mechanical change, meaning there's pressure change inside the chambers. Hence, you have opening of these valves. So, the when the pressure builds up into the from the atria, they then they later go into the left ventricle, and then essentially so on and so forth. So during systole, S1, you have the closure of the mitral and tricuspid valve. So that is the M1 and the T1. And then in your S2 shall be the closure. So during systole, the mitral and the tricuspid valves are closed, and you have ejection of blood. The semilunar valve shall open, and then transmitting the circulation, so on and so forth. So remember, the S1 is the closure of the AV valves, mitral and tricuspid, which will leave the semilunar valves open. And conversely, in diastole, the S2 shall be the closure of this, hence the opening of the AV valves. So I hope you got that. That's a review of your past year two lectures prior. So what happens when you have abnormal function? So it's just basically when the valves dysfunction, you have two major problems. It's either it becomes stenotic, or has some form of obstruction, and regurgitation. Other names: insufficiency, incompetence. So these are other terms used as in the literature, or when you go about reading about valve dysfunction. So there's a disclaimer on this one. No? A single valve can be both stenotic or regurgitant, but both lesions cannot be severe. Now that depends. But in a clinical sense, they have to be defined. But I shall not go into further details because this will. But in general, the point of this third is this third point is there is a predominant pathology. There's a predominant pathology that will dictate what particular manifestation the patient will have. Okay, so yes, they can coexist in combination. Either the single disease process, which progresses into the sequelae or complications, and or different disease processes where you have a different problem for one valve and a different problem for the other. So conversely, that means one valve lesion may cause another and vice versa. Okay, so complicated. I'll give you examples later. So our first lesion shall be your aortic stenosis. So physical exam, I think they were already elucidated that you have a mid-systolic crescendo decrescendo murmur when you do, and maybe your peripheral. Later, there's a short review about it. So basically, you have the aortic position, the aortic valve. Look at the, I hope you see my cursor. No? Are you able to, uh,
Yes po, Doc.
okay, sige. So during systole, you have the open valve. It looks like this, like a triangle, because it looks like a Mercedes-Benz. So the leaflets may be the left, right, and non-coronary cusps. Okay, so when it does open, you're looking at the short axis view from the top view of the aorta when it's open, and then during diastole, closed. So what does it look like when you have stenosis? This one is a rather, ano pa, milder form, no? So this is the closed. When you're looking up here, this one is the 2D echo, short axis view of a open aortic valve. So you can see this, open siya, no? However, if this disease ito at the bottom depiction, this is already a severe aortic stenosis with its calcifications all over the place. And this is the orifice. This is the valve that is open. Uh, this is very close to my heart, no pun intended, because I think my father-in-law was able to undergo a aortic valve procedure, which I shall demonstrate later as well as an example. Okay, so what causes it? It could be supravalvular above the valve. It may be the valve itself. It could be discrete, tunneled. And if you say the subvalvular, and if it is the valve itself, you have a congenital problem. The patient may be born with a unicusp or bicuspid aortic valve. These manifest very young. No, you have the pathology very early. So these are congenital. No? Bicuspid, maybe you see it mid to later part of life. There might be some fusion, etc. However, you see also manifestation of rheumatic heart disease for the aortic valve 40 to 60 years old. But however, when you have senile degeneration, usually around 70 years old and above. But this has changed. The spectrum has changed the past several years. So I think the trend is you're seeing younger patients with senile degenerative disease, mainly for the acquired would be rheumatic still in our country, and still we have the congenital as comprising the younger population. So this is what it looks like schematically. So your normal valve, yeah. So you have the closed and open. Rheumatic, you have fusion of the commissures. See the commissures, it tightens, no? I shall leave you the pathology. And then the calcific and the calcium deposits. This is basically atherosclerosis as well, but the mechanism is mainly very different from the coronaries as far as forming obstruction is concerned. You can see the distortion of the leaflets or of the cusps as well. You can see these circular patterns, no? These are the left and right coronary cusp and the non-coronary cusp. And if you have bicuspal cusps, you have the left, right, and then fused yung isang spot. This is the fused one. So it looks oval like that. So it can vary between the degree of stenosis and or regurgitation. Okay, so what is the pathology? Basically, inside, if you have the systemic blood pressure here, 120 over 80, what does it what's its pressure inside is a diastolic pressure of 10. Of course, because this is not a moving blood vessel, but rather a chamber which dilates. So during diastole, it's 10. During systole, you develop high pressure during contraction. So when it fills at its lowest point, starts filling at 10. So there's a gradient between the left atrium and left ventricle. Hence, you have filling of the chamber. So in patients with aortic stenosis, you can see the myocardium here is normal, the contour. Here it has become thickened, which is a hemodynamic sequelae. In the event of a stenotic valve, you can see the turbulence, no? Scattered here. So your pressure in the left atrium rises because when this opens, you still have pressure here. That basically equalizes for this to fill up the left ventricle. And the pressure you have to generate to create a systemic pressure of 110, shall be around 200 inside the left ventricle, because you have a fixed stenosis. Now, how does it look like when you translate this in the hemodynamics, meaning in the cath lab, you're able to transduce. So you can look at the left side gradient here, the pressure from 0 to 100. This is what we call the 200 scale. This is what you're seeing, the blue line is the left ventricular pressure. So the A wave, and then this is systole, no? All right, and then this is diastole thereafter when the valve. This is when the aortic valve opens, the pressure, and then the LV pressure is high, no? And then later on drops to around, if it were normal, it's around 10. Now, when you pull the catheter out from the left ventricle here, and you place it here in the aorta, this is the green line. Yeah, the green line. Now, this is deceased. As you can see, there is a shaded area. If your left ventricular pressure here on the left side, 200 siya, that's 200 over 25. So 25 here. And then when you pull out the catheter from inside the left ventricle into the aorta, you get this green one, green tracing, and it's markedly lower. So your pressure of 200 inside the left ventricle is now around 110 into the aorta. So imagine how hard the myocardium has to work to eject that amount of blood and generate systemic pressure good enough for it to perfuse your brain and other organ systems. The red line here is the left atrial pressure. So this is basically high already. So this is the end. This is the diastole. No? This is the beginning of diastole. This is the end of diastole. So basically, elevated ang left atrial pressure, which conversely becomes the diastolic pressure when the valve opens. Okay. So this is another depiction, but this left side would be this would be pressure tracing from the transducer, but you're looking at on the right column, this is by 2D echocardiography. So when you identify them in the clinic, you may see the pulsus parvus et tardus. You have them have the 2D echo done. This is just to demonstrate sometimes you get a aortic valve area of 1.2 square centimeters or whatever. However, when you do the transduction in the cath lab, if you have questions about it, the gradient here at the right side is around 36 only. No? But the peak gradient, no, is 61. So it diagnostically is aortic stenosis. So here you have a mean gradient of around 51 as opposed to 36. And the computation by the Gorlin's formula, I will not go into detail about that. All the point is you get a smaller, or so there might be some the invasive uh, can clarify the valve area. There might be some form of discordance, of course, depending on varying conditions. So what do they experience? It's tertiary dyspnea, chest pain, or angina, syncope. Later on, they have marked fatigability, weakness, peripheral cyanosis at some, cachexia, orthopnea, paroxysmal PNDs, pulmonary edema. At the end spectrum, this is heart failure already. No? So we don't want our patients to go into that. So for as soon as you're able to diagnose them, create a plan of management. So again, this is just our review. For mild, you don't have the carotid pulse, you have no LV apical pulse. You may have the systolic ejection click and the early systole. So mild or probably even sclerosis lang po ito. However, when they progress moderate to severe, you can have here the murmur, no? There's already slow rising and heaving, yung LV apical impulse. So that means left ventricle is getting hard up. So uh, then it becomes more distinguishable when it's severe. You have a rolling kind of pulse in the carotids, and the LV apical impulse is heavy and sustained. You have an S4 gallop. Sometimes you have a paradoxical S2 here. You see the blue. The pulmonic closes ahead of the aortic valve because it is too small, too tight. So you see the intensity of the S2, the A2, the aortic valve, you know, and then it becomes paradoxical when it's moderate, and it becomes widely more paradoxical in its severe form. So you see the intensity of the murmur, early crescendo decrescendo, then mid, and then later on hollow, and then it's a louder and higher pitch. So the murmur is a bush, bush, bush. Okay? Sige. So the 2D echo diagnostic criteria, just to satisfy mild, moderate, and severe. Of course, valve area. This is a prior, the valve area of less than 1. So some guidelines, the ACC, this is the Echo, American Society of Echo, and the American Cardiac uh, College of Cardiology. No? So basically, what we're seeing here, the symptoms become more manifest when moderate to severe. And they are coincided. You have in the ASC, the mean gradient is around 40 in moderate, but higher than 40 if it is severe. So if going back to this slide, what is our severity here? Mean gradient of 51 and a valve area of 0.9. Kasi ito hilaw. So this one confirms our diagnosis. So guys, what is the diagnosis here in this particular tracing? I hope to hear something. Hello? What is the severity? May I ask? May I have a response? Is it mild, moderate, or severe?
Severe.
Okay, very good. So severe siya because your valve gradient's more than, mean gradient's more than 40 with a valve area of less than 1 square centimeter. So hirap na yung heart. So what happens? It's hemodynamic consequence. You start at stage 0, your left ventricular end diastolic pressure increases. It concentrically hypertrophies because of pressure buildup. So in opposing to regurgitant lesions, which is volume, this one is pressure, so it gets tighter. No? Then conversely, because the left ventricle uh, becomes thickened and concentrically hypertrophies, the left atrium also will get it will get a feel of that particular pathology. You get eccentric hypertrophy of the left atrium, and the annulus will dilate and you will have a functional mitral regurgitation. This generates the more volume going to and from the left atrium. No? MR begets MR. Later we will understand that as well. Now, what happens? This is reflected into the pulmonary veins, into the postcapillary pulmonary hypertension. But this is the side in which the blood has its way back into the left atrium. It's called postcapillary. And then, in the pulmonary circuit, this is reflected into the to become a tricuspid regurgitation because it's already reflected in the pulmonary circuit. Your stage 4 then is defined by right ventricular dysfunction. So it's all reflected back. It is an example of a single valve that causes already disease of other valves, such as you form a mitral regurgitation, tricuspid regurgitation. Because of the volume increase in these various chambers, you may have right ventricular dysfunction. Later on, you can see along this right side of the screen is also, this is a high gradient aortic stenosis. This is classical traditional. And then on the other end of the spectrum, this is a low flow, low EF. This is preserved low flow, low gradient AS. So you still have the valve area. You can see that the mean gradient 46 here. This one drops at 35. Valve area is 0.7 here, 0.6. So you're able to compute still the valve area. So it's severe, 0.6, but the mean gradient drops. This one is what they call the low flow, low gradient. So it's already curved. You see the sharpness of the steepness of the aortic valve as it mahina na yung left ventricle. Mahina na rin ang exit niya. Here, the sharpness and peak, the left ventricle shows that it's still strong. However, at the end spectrum of the disease, you have a low flow, low gradient. Okay, so that's an example. You will eventually have left ventricular dysfunction already, becomes eccentrically dilated because of the multiple valves and multiple conditions that will cause it to fail. So that we don't want this. So this is when the patient has heart failure, pulmonary edema. Okay. So how is it treated? We have surgical aortic valve replacement. This is the partner 3 trial. Why? This has traditionally been done before. However, in the advent of the percutaneous transcatheter therapy in the form of the transaortic valve implantation or valve replacement, this has even among low-risk patients, uh, underwent TAVI. So the hazard ratio 0.87, and we can see the outcomes for TAVI in the 7 years of the partner 3 trial showed there were around 34.6 incidents of death, stroke, rehospitalization, and late valve durability. But in context, these are elderly patients. These are patients who are elderly who we have afforded 7 years of, probably they have lived up to 7 years and they looked at the outcomes. Basically, it is comparable. So this is an example of a TAVR, which was, this is actually my father-in-law. So, yeah. So this is the pre-planning. You see the calcifications, no? And then the size of the valve with an Edward Sapiens 23 and 1. There's a simulation with the wide sinus of Valsalva here. This is before, no? This is the, sorry. That's not clear. Right. Yeah. Mhm. Ayun. So we'll stop. Ayun. So I shall stop it here. So you can see this is an example of the what we told earlier, that there's a gradient. The yellow tracing is the left ventricle. So we can see on the scale here, my dad's blood pressure in the insides of the left ventricle is 160/10, more or less, no? And then when it is pulled out, when the catheter is pulled out into the aorta, the blood pressure is 120/40. Okay, so that's an example. This is before the TAVR. All right, so later on, this is sorry, this is the procedure. So we deploy it in rapid pacing. You see the ECG, we're pacing very fast so that we're able to place through the femoral artery. And then this is the wire in which it is placed inside the left ventricle, and the balloon, where the valve is mounted here, is positioned at the aortic valve position. So you can see how it's being deployed. See? So this is phased at 23. This valve size is around 23, which was measured pre-operatively. So you can see this other structures here. This is also a post-bypass patient, so very complicated case, hence high-risk push-up. Hence, we chose TAVR as the mode of valve replacement or valve intervention. Okay, so here you can see it being effaced. Yeah. So that's the valve being deployed. There is no aortic regurgitation and no coronary obstruction. You can see the left and right, so you can see it flowing. So compared to a while ago, that the gradient has now been obliterated. Wala na. Pareho na. Pantay na. So that's what you want to achieve. However, you're having some pacing pa dito. Okay, so there might be some transient heart block that occurred. Okay. So you have pace rhythm initially, later naging sinus rhythm. Later naging sinus siya. Yeah. And then another special device which we placed into the carotids to protect the brain from debris coming from the atherosclerosis in the blood vessels. These little debris can cause stroke. So this device was also used. This is from the Sentinel device, all right? So that's an example of TAVR. This is rather expensive, but if it is one of the modalities or the interventions that we are able to do. So next would be aortic regurgitation. So they can coexist. You know, the causes may be valvular, either congenital, which we discussed earlier, endocarditis, rheumatic fever, which can progress to rheumatic heart disease, myxomatous, traumatic, syphilitic aorta, which it extends beyond the root, ankylosing spondylitis. You can have root disease, mainly from the aortic root, so aortic dissection. Sometimes this can be iatrogenic in the form of coronary intervention. You can have a coronary aortal retrograde dissection, which I've observed in some of my patients when I do intervention as well. It can cause your aortic regurgitation, but fortunately, some of our aortic dissections. But if you have a problem in cystic medial necrosis, Marfan syndrome, such as the the collagen synthesis problems, these give weakness into the aortic root. So bicuspid aortic valve, non-syndromic familial aneurysms. You can see that in some patients without these collagen diseases, aortitis such as syphilis, and just plain hypertension causing the aortic root disease. So that it dilates, and then you have a diastolic murmur, labo, labo. Okay, so one of these strong, loud lesions with a thread. So these are backflow and it enters the left ventricle. Volume overload as opposed to pressure overload as a hemodynamic consequence. Then the retrograde flow during diastole in the left is low, and then the aortic pressure is high. So you have blood pressure mainly, even if your when you get the patient's blood pressure, you have a very wide pulse pressure. For example, it might be 160 over 50, ganun ka-wide, no? So it imposes more work on the LV as it has to pump normal blood flow with the regurgitated blood. So eventually, volume begets volume. It has to comply. The left ventricle has to comply with the additional volume. Hence, you have eccentric hypertrophy. So this is the physiology. No? Normal, mild, you have regurgitation, 110 over 10 inside in the LV. In the aorta, it's 110/70. Later, when you have your chronic, you see the pressure difference, 120, 150/25. Here, a wide pulse pressure, 150/50. The LA pressure is starting to rise. However, you have an acute. Pag acute siya, you have basically the same BP pa. No? The issue here is acute. So you didn't give the left ventricle a chance. So a rapid equalization of pressures because this has not complied yet. So you have a very sick patient who needs surgery right now. So there's no time to compensate for the rapid change. So the left ventricular end diastolic pressure, hence 45 ang taas niyan. Normal hanggang 18 or 12 only. But this has reflected back into the left atrium. This will reflect into the pulmonary circuit, becoming pulmonary edema. So diastolic mitral regurgitation. However, this is chronic, so your LVEDP is lower. But if you can decompensate, however, that this one is also large. So the difference here is this one has accommodated. Here, hindi pa. Here, when you have decompensation, you need to increase your blood pressure. So there's increased fibrosis, LV compliance, LV dilatation in a chronic decompensation. So you will see the symptoms in its more in its chronic state when the LV is complying. So the LV wall stress, so the Laplace, is the primary driving mechanism for volume. Yan. So there's eccentric hypertrophy, and to maintain the compliance with the volume mass ratio. And EF at this point is preserved. However, here it might lower because of the compensation to and from. So this is dynamic. It can go to and from. Ultimately, it has to be corrected. So these are physical exams, the lighthouse, malar flushing, Quincke's sign, Hill sign, the Masset's, Corrigan's, the Rutsis. So I leave it up to you to review these peripheral signs. So chronic AR, so at risk. So you know if you have bicuspid aortic valve, valve sclerosis, rheumatic heart, and then they go into progressive, but there are no hemodynamic consequences. So asymptomatic, your EF is still large, high. Or you can have severe AR also with EF of high, but definitely it starts having LV dilatation, and you have symptoms at this point. Okay, so medical therapy, of course, we need to lower the afterload so that The pressure that is reflected back into the left ventricle is reduced. So we give ACE inhibitors to prevent further remodeling. Hydralazine, or these are afterload reducers, calcium channel blockers. So, however, we talked about this, if it is in its acute form, they will go very sick. Nakita nyo nga yung, diastolic pressure has become 45. So normally it has to just be around 12. But if it goes that high, it becomes pulmonary edema. So what do we do with the valve replacement? So in stage D, of course, when it is already distorted, DEF, if less than 55, and if you have to involve cardiac surgery such as coronary obstruction, it's a class 1 recommendation. But here, I will not go into details. More importantly is why you're going to use it. So when you have severe AR in stage D, C2, and if you may need to have to undergo other cardiac surgeries and it's in some asymptomatic stage at rest, no, you may have to do a valve surgery. So moving on, we have our mitral valve. Primarily, disease mitral valve when you have MVP, rheumatic heart disease, previous IE. IE can eat up the mitral valve and looks very ugly, looks moth-eaten. And some secondary mitral regurgitation might be because of ischemic coronary artery disease or LV dysfunction. So the geometry is changed, or you have coronary problems which causes the left ventricle to suffer, dilate, and then the annulus will become dilated secondarily. So basically, they all follow the progressive, asymptomatic, severe MR eventually. So we're looking at stage A, at risk MR, stage B, progressive MR. We don't treat yet. We will just watch them. I will not go into details of this because these are echo parameters. However, when they are asymptomatic severe, we may have to start planning for surgery because later on we may have to do it in symptomatic severe patients already. So this is the schema for asymptomatic stage C for your EF of 30 to 60%. Why do we have a higher threshold? Because your ejection fraction goes two ways. Your ejection fraction into the aorta and ejection fraction of your regurgitant fraction going back to the left atrium. So we need to probably, if your heart gets bigger, dilates further, we may have to intervene. So the other new onset AFib or LVEF is still more than 60. However, these are more on to the repair. So I will not delve into this because this will require heart team evaluation. But for us to just know the class 1 indication, very symptomatic patient, severe MR, EF at least of 30, then we are able to do this. But this one, the mortality increases if your EF drops. So we have to keep it above 30. The magic number is 30 so that you will have more adequate ejection fraction after. This tells that the left ventricle is still preserved. So indications, acute symptomatic patients. Sometimes in heart attack patients, you have a rupture of the mitral valve apparatus, a papillary rupture, you have a flail, so you do surgery. But the mortality is very high among patients who have had an MI and ruptured papillary muscle, giving your acute MR, so 50% kagad. Patients in functional class 2, 3, or 4 symptoms with normal LV, symptomatic or asymptomatic patients with EF of 50 to 60 and systolic diameter of 45 to 50. These numbers are echo parameters, but generally speaking, patients with symptoms already with LV functions, basta may symptoms, no? Or asymptomatic patients with mild LV dysfunction already. So this is an example of the mosaic color flow. This is happening during systole. So the valves are closed, but there's still a jet of blood that's protruding. So let's watch it. You see? So this is open. This is systole or diastole. Open yung mitral valve. What phase is this of the cardiac cycle? Is it systole or diastole? Can I hear from the audience if you're still with me?
Diastole po.
Very good. So diastole siya. No? So when it closes, yan. So close na siya. But there is a leakage. So this is what we call mosaic color flow with a very large jet area, no? As opposed to the left atrium. So this is the left atrium. This is the anterior mitral valve leaflet. And then as it closes, there you still have some jet of blood going into the left atrium. This is what we call the mosaic color flow in color Doppler. So this is severe. It's more than 30% of the. So yeah, no. It even directs posteriorly. So when that jet of blood goes posteriorly, it has what we call the co-anda effect. It kind of hogs the posterior. So if you're going to listen to this patient, you have an anterior mitral valve problem here. Apparently it's prolapse. You can hear the lesion at your back or lateral side of your heart. Okay. So another pathology of the mitral valve is the mitral stenosis. So if one is failure to coap properly, one is stenosis. So this is the problem during diastole. It's supposedly open, however, you have a reduced mitral area. Very commonly in the Philippines, it's because of rheumatic heart disease. And very commonly we see this. So indications for intervention for rheumatic mitral stenosis, of course, symptomatic patients, stage D, asymptomatic patients, stage C. This one, I will leave it only here to the green ones, no? Whether should be in stage D. No clot in the left atrium. You do your percutaneous mitral valve balloon commissurotomy or PTMC, percutaneous transmitral commissurotomy. I am biased to do this because we do this. I do this. And this is the surgical aspect, mitral valve replacement. So patients with high surgical risk, you bridge them with this because they might not survive very well. But if they're better candidates, less symptomatic with low surgical risk, you do a valve replacement. So we do a valve replacement. So the definitions for valve hemodynamics, this is American, no? So valve area of severe MS less than 1.5. Because they found out the outcomes of the valve hemodynamics better if you intervene earlier. Okay, so we discussed that. A valve area of less than 1, this is moderate severe, but this is Filipino context. Okay, so the valve area of less than 1 square centimeter, and the gradient exceeds 12 already. So this is a lot among our patients. So when we say gradient between the left atrium and the left ventricle, and the pulmonary pressure starts to rise because of the pressure buildup inside the left atrium. So this is just a echo scoring system. So when you do a percutaneous transmitral commissurotomy approach, the contraindications would be if there's a thrombus in the left atrium that will cause stroke. A moderate to severe mitral regurgitation. if you force the balloon to, it could cause tearing, and this patient will be sent to the OR, which we avoid. Or a valve area of more than 1.5, we still avoid that because we just observe. The benefit is not as high if the patient goes into more severe forms of the mitral stenosis or aortic regurgitation of more than 2. So, which means you have to do double valve surgery already. Active infective endocarditis, so if not treated, unless it has to undergo treatment for around 6 weeks before surgery. Severe mitral valve calcification, which means a very complicated valve which could not be dilated appropriately by your balloon commissurotomy, and subvalvular fibrosis. So here you may have to place in a new valve and do some modification of the left ventricular outflow tract, the subvalvular area. So this is a video of a percutaneous approach. So you can see the Inoue balloon, which has 3 stopcocks. There's a straightening, uh, yeah. So this is a straightening tube. This is where we're going to inflate the balloon, the volume of air that we have to inject. So, but we have to place in a contrast so that we can see that in the screen when we dilate it. So this the operator is starting to prepare the Inoue balloon. Okay, so historically, this was actually invented by a Japanese surgeon rather than an interventional cardiologist, because traditionally before, mitral valves were open, the open heart surgery using what they call just poking their fingers into it, they called commissurotomy. Then they figured out how a surgical approach with a less invasive approach through balloon dilatation, so less invasive. You see, there's dilatation of the a balloon. Then there's a waist where it grabs hold of the mitral stenosis. So the LV side shall dilate to fix it. There's a tug into the on the mitral valve so that it catches the commissural, the area where it has to be dilated. You know? So you're going to fracture the commissures. Yan, so pag ganyan. So that's how the preparation goes outside of the body. And then, once that is prepared, uh, the access is through the femoral vein, and then it is slid over the guide wire into the uh, interatrial septum, and then it is now punctured. You see, there's puncturing, balloon stretching tube then after the puncture, because we will be placing the wire into the, and you can see there's a straightening tube. It will poke the interatrial septum. So you have an inner tube. Yan na. So the catheter here is through the, yan na, it will poke the interatrial septum. So move forward that further forward. Yan. So basically yan na. So now the left ventricle has been, has been approached. And now he's testing it. He replaced the stylet already, and you can see here, you're going to mount, straighten it out, yan, and then tag it now, yan, sige, position. And then later on, yan na, mag-inflate na siya. So he has it positioned. There you go. So the balloon has traversed So the proximal part of the balloon has been dilated, so you're ready now and inflate. So you can see the inflation. It's rather very hard with contrast, so you need some strength, hand strength here. So now you can see there's dilatation already of that particular valve, of the mitral valve. Okay, so this is an example of how it will look like. See, so it captures the distal end, and then this is where the mitral valve is. So it's successful if your valve area is more than 1.5 or 1.5 square centimeters. There's the drop of the left atrial pressure, of less than 18 millimeters mercury. And then over the months that you have to monitor the patient, the pulmonary pressure drops. Okay, so those who have high valve scores, or complicated valves have a greater problem with restenosis or inadequate valvulotomy. However, there's some data. We have some data at the Philippine Heart Center that we have no choice, but we have some intermediate valve scores that we're able to successfully do and have good outcomes somehow. So predominant cause of MS, rheumatic carditis, 40% with rheumatic heart disease, they progress into pure MS. And women to men, dito mas maraming women. And there's an increase in diastolic transmitral gradient. So the computation here is a gradient across the mitral valve and the LV. So the LA and the LV during diastole. So the left atrial pressure will rise. So they basically also have the same problem, the rising of the left atrial pressure, rising the pulmonary pressure. Eventually, your right side, your tricuspid regurgitation, severe TR as well. So these are one valve destroying the others. Can mitral and aortic stenosis coexist? Yes, rheumatic MS and AS can coexist, but this imposes higher mortality rate. So 10-year survival, 50 to 60% for untreated patients. But the older they get and the more that they have symptoms, the uh, the outcomes are more dismal. No? So unfortunately, I have around a few patients who consulted very late and they are in significant limiting symptoms, and very low survival rate once they become more symptomatic. So they have severe pulmonary hypertension, and then this significantly you will have a drop in. So when they rise more than 25 mean pulmonary pressure, there is the survival drops to less than 3 years. So progressive pulmonary and systemic congestion, embolism, and infection in patients, acceleration of mortality. Okay, so this we have seen. All right. So this is what it looks like on echo. You see the hockey stick. So this is in systole or diastole. So this is closed, this is open. Again, this is to the class. Is this in systole or diastole?
Systole po daw.
Systole, sarado po yung aortic valve.
Diastole po daw.
Diastole. But look at the motion. This is what we call the hockey stick sign. So there's stenosis here, so it kind of looks like a hockey stick. So in diastole, it domes. Nagdo-dome siya, bumabako ito. Instead of this one turning and touching the septum, parang mag-open, dapat siyang ganyan. But this one domes. Nagdo-dome dito. because of the pressure buildup here. And basically, the left ventricle is protected when you have mitral stenosis. Okay, so this is an example of this is how it looks like, and yan yung four-chamber view. You can see the mitral valve, very calcified. This is how it looks like in its short axis view. Yan, no, so this is in diastole, no? Open siya. Kahit pa paano, meron. Okay. Sorry. So another valve would be your tricuspid valve. Usually you have they call it forgotten kasi once you have TR, the primary mechanisms for mitral and aortic usually ang star of the show. But sometimes there might be patients with moderate to severe tricuspid regurgitation presenting with edema. So ito yung patients with probably some primary repair of the tricuspid valve. But the appropriate treatment, kasi this could be secondary, sometimes from cirrhosis or chronic passive congestion, we have severe TR. So we can, and usually during mitral valve repair, replacement, or aortic, when you have secondary changes in pulmonary pressure and there's progression of your tricuspid valve regurgitation, you will have to have the annulus tightened or a repair of the valve. So this is how it looks like. So your mitral valve here. Okay, here. The anterior mitral valve leaflet, posterior mitral valve leaflet. This is, kaya nga they call it tricuspal kasi bicuspal ang mitral valve. Anterior, posterior, tsaka septal leaflet. On the septum. Ito yung septum, di ba? So the valve that's along the septum, ito. Anterior mitral valve, posterior mitral valve, posterior tricuspid valve. So this is your tricuspid valve. Compared to the more circular annulus of the mitral valve, ito mas oval siya. You have to use your imagination. Yeah. So similar to they have cascordae papillary muscles, tricuspid annulus, and in addition to the right atrium and ventricle, it has and the moderator band in the right ventricle. Okay. Sige. So this I will not discuss that. Okay, we discussed that already. So these are views. So what causes it? Least common of forming the valve stenosis, usually rheumatic siya. So yung tricuspid regurgitation, usually more secondary siya from your initial valve problems or chronic passive congestion. However, if you have tricuspid stenosis, is very rare na isolated disorder. Usually the mitral and aortic get affected. This is rather farther from the destruction of the autoimmune process. No? So you might have congenital malformation, endocarditis, pacemaker-induced adhesions. If you put pacemakers in the right ventricle, nag-adhesion siya and you have stenosis along the lead line. Lupus valvulitis or mechanical obstruction by tumors such as myxoma. So you have here a large right atrial and the annulus has dilated. Okay. So an example, I hope this plays. I think it does not. So this is so this is tricuspid regurgitation, or here I mean stenosis, sorry. So during systole or diastole ang problem. So during diastole. Okay. So naman TR, you have 50 to 60% have mild TR. So this is basically all benign finding, 15% moderate. So this you have to watch out for. And they're mostly asymptomatic. And they are, well, you do hear a murmur, a hollow systolic murmur, but very subtle. And it can be augmented by taking a deep breath called the Carvalho's sigh. Mild degree of TR is benign, but you have to watch out for moderate and progression to severe TR in the poor prognosis. So the volume overload you can see, and they manifest as edema, peripheral edema. So the causes may be degenerative, rheumatic, functional TR, as what we have mentioned earlier, carcinoid, tricuspid regurgitation. Okay, so the annuli can get dilated. So again, it has an oval shape with minor and major diameter. So these are echo characteristics. You don't have to memorize that. What's important, ito yung big ones lang. How they, what are the changes? It billows, it prolapses, or flails. So yung degenerative types of tricuspid regurgitation. So sometimes you have the tricuspid valve prolapse, similar to the mechanism on the other side. There is stretching of it has some association with mitral valve prolapse. The coaptation line is behind the annular plane. So imagine this is the annulus, annular plane. Yung prolapse of the valve goes like that instead of on the plane. So not the posterior leaflet, but rather the anterior septal leaflet. So the phenotype is diffuse myxomatous degeneration. So rheumatic TR is less common than the left-sided valves, namely your mitral and aortic. So consequence of deformity, shortening fusion of the chordae and papillary muscles. So, sometimes now in the advent of 3D echo on top of the 2D echo, which has come a long way from the diagnostics, the images can be now be able to see some of the structures three-dimensionally. Okay. So functional tricuspid regurgitation, as mentioned, they can be from mostly left-sided heart disease, pulmonary hypertension. Once they cause pulmonary hypertension, nagdadilate na yung annulus. Sometimes congenital heart defects like Ebstein's or other congenitals, and sometimes cardiomyopathy. So the point is progressive remodeling, the right ventricle. And then the volume leads to dilatation of the tricuspid annulus, and you have papillary muscle displacement and tethering. So signs of severe TR, this is via the echo. However, you see these patients with edema, and you have elevated jugular venous pressure. So there's a question here. Wala, akala ko may question. Okay. Again, stages, I shall not discuss that, but the point of our valve intervention at any time of the left-sided valve surgery, we do that. But unless you have a primary or secondary TR with more symptoms that we have to discuss with the heart team, that which may have some benefit in treating the valve. But definitely when you're having left-sided valve surgery or coronary bypass, you have to repair that as well, since para isahan na lang opening. So our pulmonic valve, the last one, normal valve area during its systole is 2 square centimeters. Left, the anterior, the right. So it's similar to the aortic valve. It is also tricuspal, semilunar. No? So sternal short axis, you can see it's not playing, I'm sorry. So you can see here a schematic. This is the pulmonary valve. So this is a schematic. So you can see this is the right atrium, the inferior vena cava, the right ventricle. here. This is the aortic valve. Okay. Then the pulmonary artery here. Okay. So the problems that we can have is pulmonic stenosis, usually part of congenital, or if secondary to very rare. So usually congenital to MAPI asthmatic. Congenital rheumatic pulmonary stenosis, very rare ito, rheumatic. Carcinoid disease, yes. Tumors, yes. Part of the complex of your congenital lesions, your tetralogy of Fallot or double outlet RV, double outlet right ventricle. Okay, so coexistent with peripheral pulmonary artery stenosis such as Noonan's and Williams syndrome. So 10% of the congenital disease may have dysplastic pulmonic valves, so PS. So the valve commissures are partially fused and three leaflets are thin and pliant, so conical. So they have jet effect, patuis. Post-stenotic pulmonary artery dilatation may occur due to the jet effect. So what do you hear sa lesions? Similarly to the right parasternal second for the aortic valve, there's right second parasternal border for the aortic valve. You listen to the left parasternal border for your PS. So it's also an ejection murmur, high pitched. Okay. So sometimes you have a narrowing of the subvalvular component, which gives you pulmonic stenosis as well, similar. Okay, so you have associated valvular problems such as PS also with supravalvular pulmonic stenosis. So basically, it becomes already peripheral rather than a valvular problem already. So you could have obstruction beyond the valve in the pulmonary arteries or its distal branches. So they are associated with ASD, VSD, or PDAs. So how do you diagnose? Of course, there's thickening and the doming motion similar to anything that has stenosis. RV hypertrophy because of pressure overload on the RV. So there's hypertrophy. So it's hard to see systolic gradient when you do it by echo. Anyway, so that ends part one, which is our valves. So basically, what to remember in valves are left-sided. Our left-sided valves are mostly what we treat, mainly the aortic, the mitral position, in the spectrum of its stenosis and regurgitant, they can all coexist. So the benefit is higher among patients who are highly symptomatic, but the left ventricle has not lost its ability, or it's not dysfunctional enough that can make the prognosis of the patients poorer. So we have to catch them at the point that the prognosis is still good at the time we do intervention. So that's the caveat, or that's the take-home message for as far as the valves are concerned, regardless what is affected. They all have to be replaced during the time of surgery, yes, but it comes with associated higher morbidity and mortality. The longer your procedure is, the longer your recovery shall be also as well, and the complications. Okay. So next, we will go with your congenital heart diseases. So they can be cyanotic or acyanotic. So in the normal heart, the schemas on the right side. Of course, when we say congenital, we may be dealing with a lot of shunts, or there might be a problem with your pulmonary aortic positions. Likewise, within the schema of the circulation of the left and right. So we've already discussed the flow of the blood. Now, what's crucial here is if you have shunts going on in any of the chambers or any of the vessels, they can impose pressure and volume overload on the right ventricle. Compared to the left ventricle, the RV is thinner. So it can give way to what we call isomerization. We don't want that. Okay. So the blood from the body, blood flows through the IVC, superior vena cava, to the right atrium, as we said, to the right ventricle, into the pulmonary artery, and then back, going to the lungs for oxygenation, back to the pulmonary veins. Yan, pag red na, oxygenated na siya. And then through the air, through the other pulmonary veins, and then through the aorta. Back to this. So this is circulation in a nutshell. So I will not go into detail to the segmental approach, which means we have to detail the embryology of the various chambers of the heart and the various um, vasculature, such as the great vessels. So we have to say if it is in correct situs, meaning nasa left side ng predominantly ng chest, and you have no inversus, or you have your situs that is anatomical in relation to the abdominal organs. Okay, so that I will not go into detail, but in recognizing congenital heart diseases among pediatrics, that should be described. Likewise in adults as well. So atrial situs, so we can say if it is correct, it is in, not interchanged. No? So this I will not go into, but suffice to say, ito yun. The AV connections, that's LA is connected to the LV, the RA is to the RV. Sometimes there is a transposition. So later we'll talk about that. The ventricular arterial connections. So our specific congenital lesion shall be the ones with dilated right heart shall be the partial anomalous pulmonary venous return. So these are shunts. Ibig sabihin may mga butas. Or abnormal vasculature drain of a deoxygenated blood draining into a chamber. No? So partial anomalous pulmonary venous return, or PAP-VR. No? This has what we call the scimitar syndrome. Primum atrial septal defect, secundum, and the sinus venosus. So these three are atrial septal defect. So they can be primum, secundum, or sinus venosus. These are shunts. But this is interatrial, your primum, secundum, and sinus venosus. Your coronary sinus septal defect likewise. And the Gerbeaud defect from the LV to the RA shunt. From the LV, meron kang shunt going to the RA, known as the Gerbeaud defect. Or fistulas from the coronary artery going to the right atrium or the coronary sinus, so the backside of the heart. Sometimes, pag naoperahan, you might have some residual shunts still. And as mentioned earlier, the Epstein's anomaly, where the tricuspid valve insertion annuli are lower into the right ventricle. Okay? Yes. So in ASD, as opposed to the normal kanina, we have a shunt in between. So when you say shunt, meron siyang flow. We call that the Q flow, QP, pulmonary blood flow versus systemic. So QPQS, blood flow in the pulmonary and blood flow in the systemic. It should be 1:1 pag walang butas, or close to 1 if you still do not have any. But predominantly the shunt is left to right. So this is oxygenated blood going through the defect. Okay. So yeah, again, you have now a increased pulmonary blood flow. So ito, when you have a hole here, your physical exam finding is expected to have a fixed split S2, lab drip, lab drip, lab drip. Okay. So you have more volume going back into the left circuit. No? So in ASD, ito nga yung sinasabi natin normal, secundum type, yung gitnang-gitna, primum, closer to the to the inferior interventricular septum sa baba and sinus venosus sa ibaba. Okay. So NFAS, this is what it looks like sinus venosus, the secundum type and the primum, and your coronary sinus in the back. But these are the three ang ano mo. Your primum near the AV valves, secundum in the middle, and then the the sinus venosus type. Okay? So ito yun. So these are the defects. So secundum type. So this is the sinus venosus near the roof. And you have the superior vena cava type, sinus venosus. So there's one on top, there's one at the inferior vena cava and superior vena cava, and the primum, the one closer to the AV valves. Okay. Yeah. So on 2D echo, what does it look like? Ito yun. So there's a defect here, echo dropout space on 2D echo, and you see a blood flow predominantly left to right initially. So these are ASDs can be seen among children. However, sometimes they're not severe enough. You catch them into adulthood. So they can undergo what we call also I have not collected clips, but we do percutaneous closure likewise, besides surgical, which is using devices looking like buttons. So they're called Amplatz devices or ASD occluder devices. Okay, so you have fixed splitting of the S2, right? So it does not change with respiration. You may have an RV lift, so beginning na yung ano, so there's volume pressure overload already on the right side. The murmur, ejection murmur because of the blood flow going to the pulmonary circuit is less than 3.6. Now, if the shunt is large, QPQS of more than 2.5, yeah, there's a tricuspid diastolic flow rumble. So pag nagbukas yung open yung tricuspid valve, no, there is a flow rumble. Okay. So echo, of course, you have the RVH, and then complex in D2 and 3. So here, we have a pulmonary artery, the second mogul. So this is aortic, a prominent pulmonary artery. So just to see the PA view, this is right atrium, and the heart here is nothing. But when this is the PA view, this is where the pulmonary artery arises. It's more prominent. A better view for chest radiography shall be the lateral film, because you can see the RV and the sternal border. Obliteration of the retrosternal space will mean right ventricular enlargement. And pulmonary plethora, ibig sabihin yung vascular markings that have increased in the lungs. So this is primum type. Cleft mitral valve, or your AVSD, ASD primum. Even the mitral valve is affected, so you can have posterior, you can have mitral regurgitation along with it. Okay. So echo usually have the right bundle branch block for patients with ASD. You can just diagnose it with echo unless there are questions in the diagnosis, then you can go invasively with cardiac catheterization. And you have a gooseneck deformity on angiography when you inject contrast into the area. So what we do is patch closure for primum ASD repair. It's very hard to use an occluder device here because there is no good plane for effacement, to be able to, to be able to grip the walls borders as compared to the secundum type. Ito yung secundum. It's easier to place in an occluder device there percutaneously. Okay. So this sinus venosus type that is near the superior vena cava, as opposed to the inferior vena cava. So there are two types. Yan. Ito yung transesophageal echo. Okay. Let's see if this works. Ayaw mag-play. So this one naman, you can see there's a difference in the tricuspid valve attachment. So here, what is the disease? As I've mentioned earlier. So associated lesions, no, could be Epstein's anomaly. So Epstein's ito. There's tricuspid valve. This is right ventricle. This is the right atrium, but the insertion points of the tricuspid valve is not near the mitral valve annulus, but rather lower. Okay, so this is a axis of a right axis deviation, by virtue of the uh, S waves in lead one, higher R waves in we have a pointed RV. So this is like core and subort. So core and subort, similar to TRF. Basically, you can probably diagnose TOF like this. So you have an RV enlargement, hard to see here, but the right atrium is enlarged. Looks like a boot, and the echo shows both RV and LV dilatation. So what are the components of TOF? Later we go through it. So this one is an example of your partial anomalous venous return. So this is the abnormal pulmonary vein coming from going to the, this is oxygenated. So papunta na siya sa SVC. Not so much hemodynamic implication. Some patients live normally with only a partial anomalous pulmonary venous return. So the ones that comes from the heart, from the lungs, partially drain into here. What is not okay is total anomalous pulmonary venous return. Yun, problem. So with partial, it's fine. But you may, depending on the shunt size here, from the superior vena cava, it's mixed. Instead of this one going back to the LA, it goes to the superior vena cava. So you see a gradient of oxygenated blood into the right atrium. So shunts that cause dilatation, the VSTs, ito na. So a very common VST would be a systolic, holosystolic murmur similar to MRTRs, but louder at the left parasternal border with high pitch if it is predominantly left to right. Since it's a heavy arrow, we know that the LV has high pressure and volume going to the right ventricle. So this gets hurt early on, unless the shunt is small. When the shunt is small, it's louder. But if the shunt is large, the right ventricle as well will have an imposition of the burden of the pressure and volume that's coming from the left side. Okay, so again, mas malaking volume of blood going into the across the ventricular septum. Okay. So I will do the play. Let's see if this plays. Okay. So another problem is a shunt from the aorta to the PA. So this is patent ductus arteriosus. No? So the blood flow, you have a shunt that's increased volume also coming from the lungs to the pulmonary veins. So you have more volume going out into the systemic circulation. So this is what it looks like. So this is the aorta. This is the pulmonary vein. Ayan, pulmonary artery. Sorry, pulmonary artery rather. And your aorta. So there is a mosaic color flow. Likewise, its repair can be through surgery or percutaneous approach. You can use an occluder device as well. So what you hear is a pulse pressure is wide. LV impulse, and you continuous murmur. So you could have differential cyanosis of the lower extremities because of the right to left shunt. Here, in the systemic part, So after the second or subclavian, usually meron na siyang shunt dyan. So the unoxygenated blood has a mixture with the oxygenated blood. So coming into the legs, kasi after the second, the left subclavian pass. So you could have cyanosis in the lower extremities. So cyanosis can be caused because of, or in clubbing, the distal and because of the megakaryocytes are supposed to be filtered in the pulmonary circuit, goes into the extremities. All right. So you could have elective repair uh, for unexplained left ventricular overload, LV overload. However, we can use percutaneous device closures as an alternative with a very good and high success rate. Okay. So those are simpler ones, the ones you noted earlier in summary. You saw partial anomalous venous return, ASD, secundum type, primum sinus venosus, and your VSD and your PDA. So these are acyanotic, hindi siya complex. But sometimes you catch them during the early adulthood. What we should prevent from them to develop is Eisenmenger syndrome. That's pulmonary hypertension, RV enlargement to the point that the shunt has reversed, becoming right to left. That is hard. So we have to keep the shunt left to right to be able to have a good prognosis for these patients and catch them early. Okay, so next, the more moderate and complicated or complex congenital heart diseases. So, conotruncal, you know that you have, these are cyanotic at birth na. So, if they do get carried into the adult life, kaya nabuhay sila, is probably they underwent surgery. Okay, so TOF and TGAs, the transposition of the great arteries. So here, the TOF definition is right ventricular hypertrophy, which has to deal with the VSD, butas, that has the same imposition of the LV and volume, pressure and volume. So the same pressure and volume is now trying to be directed into the pulmonary circuit. So second problem would be your PS, your pulmonary stenosis. So that will have a high gradient across. Uh, or if not, there might be absenteeism of this. Okay. What else? The overriding aorta. So hindi niya ma-direct kung talaga dito siya sa LV or sa RV. So RVH, PS, VSD, and an overriding aorta. Yan yung unrepaired tetralogy of Fallot. Kaya siya tetralogy. So ito yun, VSD, right displacement of the aorta. So overriding ang tawag dyan. Anterior and rightward. RVOT obstruction. So that's the PS, either PS or your subvalvular RVOT obstruction and RVH as a consequence. So right ventricle, meron kang VSD. Your aorta does not know, but it is displaced anterior rightward. So anterior rightward. But straddling, hindi siya double outlet. Right ventricle, hindi nandito lahat. So they can survive because some way, somehow, depending on the size of the VSD, the size of the amount of overriding of the aorta, and the preservation of the right ventricle. Okay. So physical exam, as we have mentioned, varying cyanosis and clubbing. What is the sign that you can see here? This diamond, ang tawag dito, Shamrot sign. Okay. You are supposed to see a diamond. It's normal. Ito abnormal kasi na-obliterate na yung angle. Okay? So, this is clubbing. So, TUF have right RVH. So, you have peak R waves also, more of the right-sided leads or the right-sided forces show RVH. So here you have right axis deviation, 1 and AVF. So mas mababa ang ano, so mas mataas yung R wave sa AVF. You have P waves yan. So RV, volume pressure overloading load. So ito yung tinatawag na core and sublet boot-shaped heart. So this is one is repaired. What they did is to fix the VSD, you create, you dilate or create a shunt or a conduit or widen the RV to pulmonary artery uh, flow. No? So which is this one. No? Now, VSD patch para hindi na mag-override yung aorta as well. So if you catch them early, that would be good so that they don't develop into the complications of TOF. So you have D-loop transposition of the great arteries. When you say D, dexter. So ang problem here is this also incompatible with life. So you have to create an ASD. They only survive if there's an ASD. If wala silang ASD, they will die at birth. Okay. So sometimes some babies will be born with transposition of the great arteries. So it's an emergency situation where the surgeon will place a perforation in the or create an artificial ASD or widen this so that there will be so that the unoxygenated blood will not flow systemically. Okay? Kasi dito nagkakahalo. So, we need an ASD to survive. So, what do we do with these surgeries? So, there is what we call atrial switch. Ito yung mga tinatawag na Sennings. You use your patient tissues, but you have mustard as well. So, ito yung switch. Atrial switch. Itong atria ang switch. No? So sometimes you have baffles also. But nagbabara yung baffles, hindi nag-grow with the patient. So basically that was born out in Europe and Sennings mostly sa Europe yung Sennings. Then you have the arterial switch. So neo, ibig sabihin new vessels that are sewn across the vessels and then attached accordingly into the lungs and into the systemic circulation. All right, so that's how you correct the congenital heart diseases which are cyanotic. Okay, I think at this point, any questions? Kasi what will be asked for mostly would be the acyanotic congenital heart diseases, no? What are its implications, no? What are the components of the congenital, such as TOF, no? All right, and maybe a little bit lang ng important is the physical diagnosis of recognition of the of these congenital heart disease. So your competency will involve how you pick them up in the clinic, how you make your referrals, and how you're going to advise the patient on the prognosis as well. And maybe the advanced planning will be left out to the cardiologist and the heart team. Okay, so with that, any questions? Okay, if none, good morning. Sure, no questions? Mahaba-haba ito. Okay. If none, I will end it here. Thank you. So if no questions, we call it a day. Okay. Thank you.
Thank you po, Doc.
Thank you po, Doc.